I guess this is the second part of the VUR. We're talking about the diagnosis, the clinical finding, symptoms related to the reflux, symptomatic pyelonephritis, symptoms of the cystitis, renal pain, voiding, uremia, and hypertension. Symptoms related to the underlying disease like urinary tract obstruction or spinal cord disease. Physical finding during the attack of acute pyelonephritis, renal tenderness may be noted, palpitation and percussion of the suprapubic area may reveals a distended bladder secondary to the obstruction or neurogenic disease. Laboratory finding, where we can find infection, bacteriuria, biuria, serum creatinine. X-ray finding, reflux is diagnosed by the demonstration of its existence with one of the following techniques: simple or delayed cystography, voiding cystourethography, most common used. Then assess the degree of reflux according to the international grading. We're talking about the grades. Or voiding, seen fluoroscopy, radionucleotide scan, and cystography image. Clear the dilatation, the tortuosity, as we talked in the previous part. In case of diagnosed patient with VUR, we need to do assessment of the function of the kidney. We do it in order to assess the kidney function and so protect normal one and prevent its damage as early as possible. Done in the every follow-up visit for the child with the VUR to see response to the medical treatment. If the notes deterioration in the kidney function, so we will attend to the surgery option. Renal sonography, renal scintigraphy, instrumental examination, maybe we need it, urethral calibration, cystoscopy for the morphology and the position. Here we can see the sphincter, the orifice between the bladder and the ureter. This is the normal one. It's a cone called zero orifice. This one is a stadium. There is some dilatation. First, this is a second horseshoe orifice, second, and the third is wolf hole. The treatment of VUR, first one, the medical treatment. In the majority of the cases, the children with primary reflux are initially treated medically, since there is a chance of spontaneous resolution. Positive predictors for the reflux resolution include unilateral reflux, the lower grade of reflux, early age of presentation, and the male gender. The medical management, watchful waiting, maintaining urinary sterility through the advantageous use of the single daily low dose antimicrobial prophylaxis. Often antibiotics are given as oral suspension once per day and preferred at night because there's more duration of station of the urine in the bladder. We can use these at time from the night and giving the antibiotic and giving more effective. And to the child, present with the infected urine, first give high dose. So in case of there is no infection, we give the low dose to keep the urine sterile. If there is a presentation with the infected urine, first giving high dose of the antibiotic to sterile the urine, then put him on the low dose antibiotic to maintain the urine sterility. The antibiotic in the children younger than 2 months, the most common used medication is trimethoprim and amoxicillin. After 2 months of age, the antibiotic choose becomes trimethoprim silvamethoxazole, like bacteria. Then follow up every 3 months by ultrasonography, and sometimes we need to do radionuclide scanning. The surgical option for management operation is ureteric reimplantation. The indication for that option, it is not possible to keep the urine sterile and reflux persist. If acute pyelonephritis recur deposit, the pyelonephritis is recur despite a strict medical regime and chronic suppurative antimicrobial therapy. If increased renal damage, demonstrating of the serial excretory urograms or renography, congenital urethral abnormalities like ectopic ureter or ureterocele, high-grade reflux like grade 5. We can deal with that medically. The second topic is megaureter. The term megaureter is simply the descriptive name that conveys the picture of the dilated ureter. Structurally, normal ureter diameter is rarely greater than 5 mm. If it's wider than 7 to 8, it's considered as megaureter. Classification: we have reflexing, obstructed, and non-reflexing, non-obstructed. The reflexing primary, reflexing megaureter, many proin biliureter. The secondary, bladder outlet obstruction, bladder dysfunction. The obstructed one, primary functional obstruction, a dynamic segment. Secondary, elevated intravesicular pressure, post-urethral valve, and the bladder dysfunction, retroperitoneal. Third one is non-obstructive, non-reflexing, a primary, non-reflex, non-obstructed, many neonatal megaureter. The secondary, polyuria, diabetes insipidus, infection, and post-obstructive dilatation. The management is indicated for surgery, increased renal, pelvic dilatation, increased urethral dilatation, recurrent infective pyuria, secondary megaureter. Antibiotic prophylaxis should be used to protect the dilated ureter. Many cases of antenatally diagnosed megaureter will resolve spontaneously. In case of the child presenting with recurrent UTI, first see if the case is simple or complicated. If complicated, think whether the cause is anatomical or functional to ultrasound and general coronary exam. In case of the anatomical cause, the most common secondary are UBG and VUR. In ultrasound, if shows dilated renal pelvis, do voiding cystography to see the cause, whether it is UBG or VUR. UBG is uretero-pelvic junction or vesicouretric reflux. That's it. Thanks.